Welcome back to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm Amanda Mixon, here with Audrey Gibson, and this is part 2 of our EULAR Psoriatic Arthritis RhAPP Up series. In our last episode, we covered some great data on psoriatic arthritis, and today we're going to dive in more. So let's go ahead and get started. I'm going to talk about abstract AB0690. Bimekizumab demonstrated maintenance of clinical efficacy responses to 3 years in patients with active psoriatic arthritis from 2 phase 3 studies. All right, so the overview of this study, this was a post-hoc analysis evaluating the long-term durability of bimekizumab treatment responses in patients with active psoriatic arthritis across 2 phase 3 clinical trials. Investigators assessed whether patients who achieved meaningful clinic responses early in treatment were able to maintain those responses through 3 years of follow-up. The background and purpose of this study, so psoriatic arthritis is a chronic inflammatory disease in which some patients experience waning treatment responses over time. Sustained disease control is therefore an important therapeutic goal. Bimekizumab, a monoclonal antibody that selectively inhibits both IL-17A and IL-17F, have previously demonstrated efficacy across joint and skin outcomes in psoriatic arthritis. This analysis aimed to evaluate long-term maintenance of response in both biologic-naive patients and patients with prior inadequate response or intolerance to TNF inhibitors. The methods were the analysis included data from phase 3 B optimal and B complete studies, along with the B vital open label extension trial. Patients received bimekizumab 160 milligrams every 4 weeks. Investigators assessed maintenance of key efficacy outcomes, including ACR 50 response, PsA 100 skin clearance, and minimal disease activity from week 16 through approximately 3 years. Both biologic-naive and TNF inhibitor inadequate responder populations were evaluated. The results of this study were that a large proportion of patients who achieved early clinical response maintained those responses through 3 years of treatment. Among patients achieving ACR 50 at week 16, approximately 79% of biologic-naive patients and 81% of TNF inhibitor inadequate responders maintained response at year 3. Durable skin responses were also observed, with PsA 100 maintained in 66% of biologic-naive patients and over 81% of TNF-IR patients. Minimal disease activity responses remained durable as well. Notably, many patients never lost their ACR 50 response during the entire follow-up period, highlighting the consistency of long-term disease control with bimekizumab. The authors' conclusions were that bimekizumab demonstrated sustained long-term efficacy across joint, skin, and composite disease outcomes through 3 years in patients with active psoriatic arthritis. Most patients who achieved meaningful early responses maintained those benefits over time, supporting the durability of dual IL-17A and IL-17F inhibition in both biologic-naive and TNF inhibitor inadequate responder populations. So exciting. Audrey, what do you think?
Well, I think, if we think about our, again, patients that we see every day, I think, we've all had those patients that we put on a therapy, they've done amazing, and then over time, they've had that waning of their therapeutic response. And there's nothing more like heartbreaking for us, for me anyway, as a clinician, to see patients who are doing so well, and then all of a sudden the drug just stopped working. So again, you're trying to pick that therapy that is going to keep their inflammation under control, but also have that, durability over time so that they stay in that low disease activity for a very, very long time. And so to see this data come out that, it supports the fact that if we put patients on bimekizumab, that they'll be able to maintain that durability of response over a long period of time. I think that's really impactful and significant, when looking at patients and picking therapeutic options.
Absolutely, and I remember when, this therapy first came out, they thought maybe that was something to do with this 17F
Hmm.
piece of it, and, potentially that would allow for a more sustained benefit, and that's kind of what this study is showing, and, I think it means something, when we're thinking about which agent to use. Obviously, we have reasons why we use each individual one, but this is, pretty impactful to me to know that, if I have patients that I'm thinking about starting on an IL-17, we have data out to 3 years that, hopefully they'll have that sustained response. And the other thing too is even if they had already failed a TNF, I think
Hmm.
that that's also really exciting to know that those patients potentially will have that maintained response because we always have learned that okay, the first therapy you put a patient on that's their best chance for success. And the further down the line you go, obviously the efficacy may not be as high. The sustained response may not be as great. These are more refractory patients. So to see a study that reveals that out 3 years, these patients are still doing well, I think is really impactful for me.
No, totally agree.
Okay. Do you want to get us started with
Yeah.
another abstract?
All right, so let's get into the second abstract. This is poster 0480. This is gazelkamab response and inhibition of structural damage progression in active psoriatic arthritis across APEX participant subgroups. So, the overview of the study: this subgroup analysis from the Phase 3b APEX trial evaluated the consistency of gazelkamab efficacy across different patient populations with active and erosive psoriatic arthritis. Investigators assessed both clinical response and inhibition of structural damage progression in biologic naive patients receiving gazelkamab versus placebo. So the background here is that gazelkamab is a fully human monoclonal antibody targeting the IL-23 P19 subunit and is approved for several immune-mediated inflammatory diseases, including psoriatic arthritis. Prior APEX data demonstrated significant improvement in joint symptoms and inhibition of radiographic progression with gazelkamab compared with placebo through week 24. This analysis aimed to determine whether these benefits were consistent across clinically important participant subgroups, including varying degrees of inflammation, erosive disease, body mass index, and methotrexate use. So, looking at the methods here, APEX is an ongoing Phase 3b randomized, double blind, placebo controlled study evaluating biologic naive patients with active PsA and at least 2 erosive joints despite prior non biologic therapy. Patients were randomized to gazelkamab every 4 weeks, gazelkamab every 8 weeks after loading doses, or placebo. Outcomes include an ACR20 response and change in PsA modified van der Heide Sharp score at week 24. Subgroup analysis evaluated treatment effects across baseline clinical, laboratory, and radiographic characteristics. So when they looked at the results, what they found at week 24, ACR20 responses were achieved by 67% of patients receiving gazelkamab every 4 weeks and 68% receiving gazelkamab every 8 weeks, compared to 47% receiving placebo. Improvements in joint disease activity were generally consistent across multiple patient subgroups, including sex, BMI, joint involvement, and concomitant methotrexate use. Gazelkamab also significantly inhibited radiographic progression with lower mean changes in van der Heide Sharp scores versus placebo. Patients in the placebo arm with higher inflammatory burden, including swollen joint counts greater than 15 and CRP greater or equal to 2 milligrams per deciliter, experienced the greatest structural progression, further emphasizing the protective effect of gazelkamab in higher risk populations. So the authors' conclusions were that guselkumab demonstrated significant clinical improvement in inhibition of structural damage progression in biologic-naive patients with active and erosive PsA. These benefits were generally consistent across a wide range of patient subgroups and baseline disease characteristics. The findings reinforce the importance of early control inflammation and suggest guselkumab may be particularly impactful in patients at the highest risk for radiographic progression. All right, so let's dive into this one. What are your thoughts?
Well, obviously we want our patients to feel good, right? We want to put them on a therapy and then they feel like they don't have the disease anymore. But also, we want to make sure that we prevent, radiographic progression of the disease. And so, as I look at this study, I think that reinforces that. And, that's important to us because sometimes, how a patient feels and then what's happening under the surface are not exactly the same thing. And so, again, as I look at this, I just think, well, that's great. We have data that shows that this,
Mhm.
does, impact that radiographic progression. And so I think that's awesome for this drug.
I totally agree. I know, again, patients come in and if they have family members and, that have deformities and damages, and that's always one of the first things that they ask me is, are they going to turn out, like their grandmother or their grandfather? And again, when kind of looking at treatment options, going through treatment options to have that data to support that they shouldn't have any structural progression is really important and really important to patients. I think the other thing that was kind of, it wasn't as big of an impact, but it's still clinically important is that they saw the same response, regardless of BMI, regardless of sex, all of those factors that we see in our patients, that there wasn't really any difference there. So again, that makes it easier for us, to prescribe to patients without having to worry about if there's any underlying differentiating factors between those patients.
Absolutely. And of course, this is a 24-week trial and we need it further out. It is kind of the one thing that I would also say is I want to see the data at a year, at 2 years, at 3 years, because obviously we want to know that the therapy, which I presume it will, but that the therapy will have that, consistent response and that will continue to inhibit radiographic progression. Well, that wraps up part 2 of our EULAR Psoriatic RhAPP Up series. Thank you for listening, and don't miss part 3, where we will cover even more psoriatic arthritis data from the 2026 EULAR Congress.